afternoon everyone. My name is Dr. Abhay Pota. I am Assistant Professor in Pediatric Cardiology. We will be discussing today about understanding congenital heart disease, a primer on key concepts and terms. We will be discussing about physiological terminologies and concepts and certain common eponymous surgeries which are named after so and so persons. Physiological concepts and terminologies. So we will be discussing about what is shunt, how do we determine PA pressures in different conditions, what is Eisenmenger physiology and different types of physiologies, and lastly we will be discussing about Fontan fenestrations, integrate flow and circular shunt. First of all, shunt physiology. So what is pulmonary blood flow? QP. QP is entire blood flow that blood flow that is passing through pulmonary vascular bed. What is systemic blood flow? Systemic blood flow or QS is entire blood flow that is passing through systemic vascular bed. What is QEP? Effective pulmonary blood flow. Effective pulmonary blood flow and pulmonary blood flow are different. Effective pulmonary blood flow is that flow of systemic venous blood into the pulmonary circulation, that is the deoxygenated blood that is being sent to the lungs to undergo oxygenation. Effective systemic blood flow of pulmonary venous blood into the systemic circulation, that is the oxygenated blood that is being sent to the body to deliver oxygen. Amount of oxygen absorbed by the blood circulating in the lungs must equal the amount of oxygen delivered by the blood circulating to the body. Hence, QEP must always equal QES. In a completely normal heart, QP is equal to QEP, QS is equal to QES and QP is equal to QS. So, definition of shunt. What is left to right shunt? Flow of blood which has already completed its circulation to the lungs and yet is being sent to the lungs once again without going to the systemic circulation. Say for example, in case of a VHD, pulmonary venous blood which has already completed one cycle through lungs is again shunted via VHD from LV to RV and then again going to lung. That is called left to right shunt. Then right to left shunt, flow of blood that has already completed its course through the systemic circulation yet is being circulated once more to the systemic circulation without passing through the pulmonary circulation. So say for example, in case of a right to left shunt VHD, blood is coming from SVC to RA to RV. Now without going to lungs, it is now going from RV to LV and then to aorta via VHD. So that is called right to left shunt. It is not getting oxygenated. That is called right to left shunt. In hearts with simple left to right shunts, the flow being shunted into the pulmonary circulation across the defect is additive to the flow coming in normally from the systemic veins to enter the lungs. Hence, QP is equal to Q effective pulmonary blood flow plus left to right shunt. Say for example, X amount of flow is going from RV to pulmonary artery in case of VHD. So now it is having two types of blood flows in it. One is that is coming from SVC and IVC to RA to RV to go to PA. That is one, that is effective pulmonary blood flow. That was a deoxygenated blood and now hence it is coming to PA for getting oxygenation. Next is left to right shunt. Left to right shunt is basically pulmonary venous blood that was once oxygenated but it is coming from LV to RV via VHD and it is again going to lungs for oxygenation. So that is left to right shunt. So total of both of these is actual QP. So if there is effective pulmonary blood flow, that is blood flow that is coming from SVC and IVC, and there is left to right shunt that is coming via VHD. So total of both of these is called total pulmonary blood flow. So let us discuss about pulmonary artery hypertension. So in normal heart, how do we know about pulmonary artery pressures? So in normal heart, we take TR gradient. TR Gmax indicates RV systolic pressures. Peak PR indicates RV diastolic pressures. Then say for example, in case of VHD, how do we measure PA pressures? So in case of VHD, we don't take TR. What we take is gradient of VHD. So say for example, in cases of a 10-year-old child who has got BP of 120, there is a VHD gradient of 70. So aortic pressure is 120, LV pressure is also 120, LV systolic pressure is 120, there is a gradient of 70 in VHD, so RV pressures are 50. During systole, RV and PA pressures are same in the absence of pulmonary artery in absence of pulmonary valve stenosis. So the thing is that PA pressures are 50. So this is how we take PA pressures in case of VHD. Now in case of TOF, how do we take? Say for example, if we take TR gradient in case of TOF, what will be TR gradient? In TOF there is always severe PS. So if we take TR gradient, we will find that there is, say for example, TR Gmax of 90. So what we commonly mistake is that we write that TOF with severe PS with severe PA just because we have taken TR gradient. So TR gradient should not be taken to indicate, TR gradient does not indicate PA pressure in all the situations. Next is TGA VHD. Say how do we take, how do we know that whether PAH is there or not in case of TGA VHD? So in case of TGA VHD, what will be the shunt? So shunt will be right to left. Shunt will be exclusively right to left. But while in normal VHD, shunt will be exclusive left to right. While in TGA VHD, it will always be right to left. But if the shunt is getting left to right in case of TGA VHD, then we can tell that there is pulmonary artery hypertension. How do we know about PA pressures in case of truncus? Pulmonary arteries are supplied by aorta. So from a common trunk or say aorta. So PA pressures are always high. So there is PAH is always there. We don't need to take TR gradient for that. PA pressures are systemic in case of truncus. Now is in case of single ventricle. Say there is a case of DILV. DILV with VA discordance. DILV with VA discordance means that LV is giving rise to PA and aorta is getting risen from a small ventricle. So the thing is that here if there is no PS, pulmonary blood flow is unobstructed, how do we know what is the PA pressure? PA pressures are systemic because there is only a single ventricle that is LV and other one is outlet chamber that is giving rise to aorta. So there is a single ventricle that is nearly giving rise to aorta and PA both. So and there is unobstructed pulmonary blood flow, so PA pressures are systemic, they are equal to aortic pressures. So we don't need to take Gmax in this situation also. So there are multiple situations in congenital heart defect where Gmax does not reflect pulmonary artery pressures. What is hyperkinetic PAH and obstructive PAH? For a variable period of time after pulmonary vascular resistance starts to increase, changes in lung vasculature may still be reversible following correction of the defect. Say for example in case of VHD, that is called operable situation. However, once irreversible pulmonary vascular obstructive disease is established, closure of the defect may actually worsen the natural history and worsen the patient. So that is inoperable situation. So PAH with increased pulmonary blood flow versus PAH with decreased pulmonary blood flow. Hyperkinetic PAH means that PAH is there but with increased pulmonary blood flow, while obstructive PAH means that patient is now in inoperable situation and there is PAH but with decreased pulmonary blood flow. This obstructive PAH is also known as Eisenmenger physiology. Hyperkinetic PAH is commonly seen in shunt physiology, obstructive PAH seen in Eisenmenger physiology. So what is Eisenmenger physiology? Pulmonary hypertension at systemic level caused by a high pulmonary vascular resistance with reversed or bidirectional shunt at aortopulmonary, ventricular or atrial level. This represents the most severe hemodynamic phenotype of PAH in association with CHD. It indicates development of pulmonary vascular obstructive disease or obstructive PAH. It develops in presence of large unrepaired atrial or ventricular septal defects, arterial shunts or complex forms of CHD such as univentricular hearts, that is single ventricular physiology with unrestricted pulmonary blood flow, as we have discussed earlier, a case of DILV with VA discordance. Then what is difference between PVR and PVRI? Pulmonary vascular resistance describes the resistance that blood must overcome to pass through the pulmonary vasculature. PVRI, pulmonary vascular resistance index, relates the absolute value of PVR to the patient's body surface area to account for the effect of body size on blood flow. This is very important in case of pediatrics, but here units are very important. We should not divide or multiply these PVR values to derive PVRI in case of pediatrics, because whatever charts that we are using are already indexed for body surface area. So whatever PVR we are getting is actually PVRI. So we should not neither divide nor multiply them. with body surface area to derive PVRI. What is top physiology? Top physiology basically means that there is a large communication at VSD level and varying degrees of obstruction to pulmonary blood flow. So VSD, PS. PS saturation in case of top physiology is less than aortic saturation. What are the examples of top physiology? Top pulmonary atresia, DORV VSD PS, TGA VSD PS, CCTGA VSD PS, AVCD VSD PS, and single ventricle VSD PS like tricuspid atresia VSD PS or DILV VSD PS. What is admixture physiology? Complete or almost complete mixing of systemic and pulmonary venous blood, and then ventricle pumps both this blood to both systemic and pulmonary circulation. That is parallel circulation. So distribution of systemic blood flow and pulmonary blood flow depends upon SVR and PVR. If there is admixture at RA level, like in case of mitral atresia or HLHS, admixture at LA level in case of tricuspid atresia or PIVS, or admixture at ventricular level, DILV, DORV, DIRV. These are the examples of admixture physiology. What is streaming? Say there is blending of blood from both systems in same chamber. So final saturation is generally average of systemic and pulmonary venous saturations. But in some cases, streaming of blood is there. That is direction of flow into a particular great vessel. The pulmonary venous return can preferentially stream into aorta, precluding complete admixture and result in higher oxygen saturation in aorta than PA. Then it is called favorable streaming. Conversely, the pulmonary venous return can selectively enter the pulmonary artery, resulting in higher oxygen saturation in PA than aorta, also called as unfavorable streaming. So, favorable streaming is seen in DILV with aorta from left-sided outlet chamber. High saturation as oxygenated blood of oxygenated pulmonary venous blood is directed into aorta. Unfavorable streaming seen in DILV with aorta from right-sided outlet chamber. Low saturation as oxygenated pulmonary venous blood is directed into pulmonary artery. What is single ventricle physiology? Single ventricle physiology exists when there is impossibility or inadvisability of surgically reconstructing a functional two-ventricle heart with in series separated systemic and pulmonary circulations. This is the definition of single ventricle physiology. Essentially, it is an admixture physiology. Then certain circulatory terms, balanced circulation. It is equitable pulmonary and systemic perfusion. QPQS is nearly 1. It depends on SVR and PVR. Results in maximum oxygen delivery to tissue at tissue level without causing heart failure. So QPQS of 1 is called balanced circulation. What is parallel circulation and series circulation? Parallel circulation and series circulation. Our normal circulation is in series circulation. Parallel circulation is seen in case of fetus. Say in fetus, RV and LV both are pushing blood into systemic blood flow. While after birth, RV is pushing blood into pulmonary artery and LV is pushing blood to aorta. That is normal blood flow, that is in series circulation. But also erroneously, it is sometimes TGA is sometimes known as parallel circulation, where RV is pushing blood to aorta and LV is pushing blood to PA, but parallel circulation is mainly seen in fetus. What is duct dependent systemic and pulmonary circulation? Duct dependent systemic and pulmonary circulation are seen in cases of say for example in duct dependent pulmonary circulation, pulmonary atresia is there. So pulmonary blood flow is mainly dependent on PDA being open. In cases of aortic atresia or interrupted arch, systemic blood flow is dependent upon PDA being open. So that is duct dependent systemic circulation, and pulmonary atresia cases are duct dependent pulmonary circulation. Fontan physiology. Fontan physiology is basically what Fontan does is then it achieves in series separated circulation as against in parallel. Say for example in cases of DILV, as we have discussed earlier, a single ventricle is pushing blood to both LV as well as LV is pushing blood to both aorta as well as PA. That is parallel circulation. What Fontan achieves is that it leads to in series, that is normal separated circulation. This is done to counter two main drawbacks of single ventricle physiology, that is increased volume overload or heart failure and cyanosis. What is Glenn circulation? It is a in series circulation but with an obligate 40 to 60% of right to left shunt, as IVC still drains to the ventricle to aorta. What is Fontan circulation? It is also a series circulation with systemic venous return enter into pulmonary vascular bed in series. What is antegrade flow and fenestration? Any amount of pulmonary blood flow passing via pulmonary valve in a case of single ventricle after Glenn or Fontan palliation is called antegrade flow. So basically a case of PS, say for example in case of Glenn, if MPA is ligated, then or there is pulmonary atresia is there, so there is no blood flow to pulmonary vascular bed coming from ventricles. That is called no antegrade flow. No antegrade flow across pulmonary valve. Full term is no antegrade flow across pulmonary valve. But in certain cases either MPA is not ligated along with Glenn surgery, or there is a severe PS is there. So now there is a certain amount of blood flow, very minimal blood flow, but a certain amount of blood flow is coming to pulmonary vascular bed from LV or RV, whatever ventricle, through pulmonary valve. That is called antegrade flow present. What is fenestration? Fenestration means creating a communication or hole between IVC to PA conduit and RA in cases of Fontan, in turn leading to right to left shunt. There is a communication between conduit and RA. That is called fenestration. It reduces volume overload but at the cost of mild cyanosis. What is circular shunt? Circular shunt is a condition in which blood from a cardiac chamber is diverted through the heart to return to the original chamber without reaching the pulmonary capillary bed. Circular shunt is prompted by the combination of pulmonary insufficiency or PR and TR causing continuous retrograde ductal flow and intracardiac recirculation which results in low tissue perfusion and a life-threatening condition. Example is, say for example there is a PFO is there causing right to left shunt. Blood is going from PFO to right to left shunt to LA to LV to aorta, then to via PDA to PA. Now if there is PR is there, blood from PA is going to RV. Then if there is TR is there, this RV blood is going to RA, and again via PFO it is shunting right to left. So this is called circular shunt. Blood is neither going to aorta nor to PA. It is just circulating inside heart. So this is circular shunt. It is seen in cases of PAIVS with RVOT perforation and PDA stenting, or in case of large PDA with RVOT perforation. So our third discussion topic is eponymous surgeries. Eponymous surgeries means certain surgeries which have certain names attached to them. I have divided them into two parts: corrective surgeries and palliative surgeries. Corrective surgeries are Rastelli and Ross. Ross is aortic valve replacement with pulmonary autograft and RV to PA conduit. So here in cases of Ross, say for example Ross is done where there is either severe AS or severe AR in a relatively young child, where pulmonary valve is placed in place of aortic valve, and there is RV to PA conduit is placed. What are the palliative surgeries? Certain palliative surgery examples are Senning, Norwood, DKS, Seno, BT shunt, central shunt, Glenn and Fontan, PA bend and Kawashima. What is Rastelli? Rastelli is basically VSD closed with intraventricular tunnel repair. So this VSD that was closed, and there is RVOT reconstruction by most likely by RV to PA conduit. So this is RV to PA conduit. So VSD closure, RV to PA conduit. This is done in case of DORV or DTGA VSD PS. It requires a routable or committed VSD, as we have discussed earlier. What is routability? Senning surgery. It is done in cases of DTGA intact IVS with regressed LV. Generally done after 2 to 3 months of age. There is interatrial baffing. Baffle is done using autologous atrial tissues. If autologous atrial tissue is used, it is called Senning surgery. So it diverts blood from SVC and IVC to LV to PA. This one is systemic venous baffle. It is diverting IVC and SVC blood which is desaturated to LV to PA. And pulmonary venous blood is getting diverted via RA to RV to aorta. Pulmonary venous blood is getting diverted via RV to aorta. So this oxygenated blood is reaching into aorta, deoxygenated blood is reaching to PA. But problem here is that left ventricle is pumping blood into PA and right ventricle is a systemic ventricle and pumping blood into aorta. Here RV acts as a systemic ventricle. What is Seno shunt? Seno is basically a RV to PA shunt. RV to PA shunt, it is non-valved. In cases of Rastel, we were putting a valved conduit. Here it is a RV2 patient, but it is non-valved. Mainly done in cases of top physiology, that is VSD-PS situation. What is Norwood? Norwood is a surgery which is done in neonatal age group, which comprises of three parts. One is DKS. DKS means Demuskai Stansel surgery. That is transaction of MPA near bifurcation and side-to-side anastomosis with ascending aorta. So MPA and ascending aorta anastomosis plus atrial septectomy plus BT shunt or Seno shunt plus BT shunt or Seno shunt plus minus arch repair, plus minus arch repair. This is mainly done in cases of HLHS. DKS plus atrial septectomy plus BT shunt or Seno shunt plus minus arch repair. What is BT shunt? It is shunt between ipsilateral subclavian artery and PA. So that is right subclavian artery to RPA or left subclavian artery to LPA. It is done in cases of top physiology as well as we have seen as in cases of HLHS. What is Glenn shunt? Glenn shunt is RSVC to RPA or LSVC to LPA connection. RSVC to RPA or LSVC to LPA connection. There are two types of, two certain terminologies related to Glenn: bilateral and bidirectional Glenn. Whatever Glenn we are doing these days are basically bidirectional Glens. Bilateral Glen means RSVC to RPA, LSVC to LPA. If there is no LSVC, it is just Glen. If it is or unilateral Glen, if there is LSVC to LPA, then it is bilateral Glen. LSVC to LPA, RSVC to RPA. It is second stage of single ventricle palliation. What is third stage of single ventricle palliation? That is Fontan. Fontan is connecting IVC and hepatic veins to RPA. IVC and hepatic veins are connected via PTFE conduit placed outside RA, that is extracardiac conduit, diverting blood of IVC and hepatic veins to RPA. What is 1.5 ventricle repair? 1.5 ventricle repair is a combination of BD Glenn surgery or Glenn surgery in association with intracardiac correction for a small subpulmonary ventricle. It is also referred to as partial biventricular repair. As we have seen, there is true biventricular repair or corrective surgeries, partial biventricular repair, and lastly single ventricle repair. So three types of repair can be possible: total correction or biventricular repair, single ventricle repair, and partial biventricular repair. Partial biventricular repair is 1.5 ventricle repair. This concept has been applied to situations where one ventricle is capable of pumping 1/2 of the circulation. That is, say for example, LV is able to pump blood to aorta while the other ventricle is deemed inadequate and requires offloading by means of a Glenn. So say for example, RV is bipartite instead of tripartite. So for example, in cases of PA IVS with bipartite RV or small RV in cases of Epstein anomaly, RV is unable to push blood to PA. So we offload some of the RV inflow in form of SVC is connected to PA. So SVC blood is directly going to PA while IVC blood is coming to RV, and via RV it is going to PA. We have already perforated pulmonary valve in cases of PA IVS in newborn age. So now some food for thought questions lastly. First of all, which area should be described as VSD in DORV? There is certain terminology called aorta to LV communication or aorta to RV communication. This is very important to know. What is the exact location of VSD? There is a very huge difference between what we label as VSD and what surgeon closes by patch in case of DORV. Next is, what is restrictive RV physiology in TOF? And what is its effect in postoperative stay? What is the difference between Glenn, Kawashima and Fontan surgery? As I discussed earlier, there is certain operation called Kawashima. That surgery, Kawashima surgery is different from Fontan, and it is also different from Glenn. They are also very similar, but they are also different also. So what is the difference between them in case of single ventricle with interrupted IVC? So say for example, Glenn is done in case of single ventricle, Kawashima is also done in case of single ventricle, and Fontan surgery is also done in case of single ventricle. And if there is interrupted IVC is there, what is the difference between all three terms? Thank you.